Hello, this is our donor anatomics records project for our Tank 1 anatomy group. Our patient cadaver was a 72-year-old Caucasian male. His occupation was a chef, and the listed cause of death was brain cancer with metastasis to the bone, with the date of death being September 20th, 2017. So during our dissection, we noticed several anatomic variations. First and foremost, we did notice a unilateral craniotomy over the right hemisphere, most likely, which was contributed to due to the resection of his primary brain mass. We did also notice some mild cerebral edema, possibly secondary to the growth of his brain lesion or tumor with obstruction of cerebral spinal fluid. But we also did notice during our thoracic dissection coronary artery stent placement, potentially due to any kind of plaque development or suspected stenosis. Then we also, during our inspection of his lung tissue, we noticed what we suspected was, and later confirmed, was emphysema in the right lung, with the left lung having very dense, suspected potentially a tumor infiltration, which was later confirmed to be necrotic and just potentially inflammatory tissue. We also noticed a mild bilateral uncal herniation, and were able to palpate gallstones, possibly developing postmortem. And then we also were able to detect very easily rib fractures, with also pulling of blood along his back, which was we suspected was due to CPR and chest compressions. So after doing tissue dissections of his lung tissue, we were able to confirm his what we suspected was emphysema in his right lung. It was very apparent on microscopic analysis, the alveolar wall destruction. We were able to confirm this after consulting with a pathologist that this was indeed emphysema present in this lung tissue. However, on the left lung, what we suspected might have been tumor growth or further metastasis was a little inconclusive. After consulting with a pathologist, it seems that maybe this was just strictly necrotic or inflammatory tissue. It was fairly inconclusive of what we might be looking at here. So we weren't entirely sure of what may have happened in his left lung. So just a little bit further background on emphysema. Pathology includes just damaging and weakening of the alveolar wall, leading to alveolar rupture and clear reduction in ventilation. Could be contributed to multiple factors, a lot of times environmental, but also smoking, and as well as some genetic predispositions or a combination of all of the above. And a lot of times patients will present clinically with shortness of breath, as well as use of accessory muscles for breathing, which can develop into a large barrel type chest, and can sometimes cough with or without sputum. So a lot of times emphysema can be diagnosed with coronary function tests, which kind of a key signature can be sometimes a large functional residual volume on expiration, but it also can be confirmed through imaging, through radiographs, as well as a CT scan, which can be sometimes a little bit more detailed and definitive. And once diagnosed, these patients can be managed therapeutically with bronchodilators, sometimes in combination with anti-inflammatory drugs, as well as supported therapy with oxygen and ventilatory support, any kind of pulmonary rehabilitation. And then in very severe cases and disease progression, surgery can be consulted and potentially considered for lung transplant in very advanced stages. So clearly this can have a significant impact on a patient's life, and decrease their overall quality of living, physical capabilities, exercise tolerance. It also can increase their experience, their frequent pneumothoraces, and all the above can contribute to the development of any kind of psychological manifestations such as depression, anxiety, which can reduce or have a large contribution and decrease in patient health. So we're also able to confirm and notice during our section a craniotomy with a tumor resection. We suspected there was likely some presence of mass effects, potentially pain, headaches, obstruction of CSF flow, maybe some potentially neurological manifestations of the growth, and possible resection. So surgical resection can be sometimes preferred for patients with a single and accessible lesion, which seemed to be the case with our particular patient. And sometimes surgery plus whole brain radiation therapy can be shown to be superior as far as survival rates rather than surgery or brain radiation alone. So we suspect that he may have also undergone some potential further post-operative radiation to try to prevent any kind of tumor relapse. He also presented with bone metastasis from his primary brain lesion. A lot of times bone metastasis, one of the significant manifestations can be pain, can impact the patient's quality of life. This pain can be derived from stimulation of the periosteum and endosteum receptors, which has to be managed through multiple disciplinary therapies such as localized radiotherapy, as well as non-steroidal anti-inflammatories for some mild pain, but in severe cases can be managed with opioid analgesics. And then any neuropathic pain that can manifest can be managed sometimes with gabapentin and or tricyclic antidepressants. So some of just general treatment modalities for any kind of bone metastasis is a lot of times treated with a combination approach of chemotherapy, as well as bisphosphonates due to a multifactorial therapeutic approach, as well as denosumab, which is known to inhibit the rank and wrinkle system to try to reduce any kind of osteoclast activity or upon resorption. So just to quickly summarize, our patient suffered from a brain cancer with metastasis to the bone. We suspected there could have been possible neurological deficits due to brain mass growth and also surgical complications from the resection. His bone metastasis likely contribute to significant pain and any kind of reduction in physical capabilities and his quality of life. And then any other potential complications may have occurred also due to cancer treatment therapies and known high rates of toxicities. But also, we suspected he probably had further complications due to his emphysema and any kind of compromised pulmonary function had significant deleterious impacts on his health and possible contributed to his ultimate death. So our suspected cause of death was pretty consistent with the death certificate, albeit maybe with some further complications. We suspected it was likely primarily due to progression of his primary brain cancer and further metastases, but also his pulmonary functioning and pathologies likely contributed to some disease progression, as well as any kind of cardiac functioning that may have been present with the wears done during our dissection and the presence of a stent. So we think that it was just maybe an overarching impact on his quality of life due to a combination of multiple pathologies. So these are just some of the references that we use to gain some further background information on some of his observed pathologies. And so this concludes our presentation on our donor anatomic records project. Thank you.